Good afternoon. My name is Colleen. I'm a student nurse practitioner, and today I'm going to insert a central line, and the site that I'm going to use is the internal jugular. The indication for this procedure are emergency venous access, administration of TPN, administration of high volume fluid resuscitation, caustic agents, vasoactive agents, and administration of concentrated fluids. The absolute contraindications are infection over site of placement, existence of venous thrombosis in the target vessel, pathologic conditions such as superior vena cava syndrome, patient allergy to the impregnated catheter antibiotic. Before we start the procedure, we have to make sure that we obtain informed consent and that we explain the associated risks of this procedure to the patient. The risks are infection, air embolism, nerve injury, arterial puncture, hemothorax, and pneumothorax. This is a sterile procedure, but an ultrasound guided procedure as well. But before we start, before we kind of like lay down our sterile field, we're gonna use the ultrasound machine to locate our site, our vessel. We're gonna assess the vessel just to make sure that the vessel is not stenosed, the vessel there's no thrombus there, and that the vessel is very compressible. This is the site where we're gonna insert the catheter, and it's located in that triangle section. This is the jugular vein, and this is the carotid artery. The carotid artery is very close to the jugular vein, but the difference between the two is that the jugular vein is very compressible. So we use our ultrasound machine, we locate, we go along, we do the long and short axis. The long axis let us see the state of the vessel, okay? And once we look at our vessel, we can mark it down with a surgical pen. Of course, it has to be a sterile surgical pen. So now we make sure that the field is sterile, and then we can start the procedure. This is the ultrasound. We inject the patient with 1% lidocaine in the surrounding tissue, and we wait 3 to 5 minutes to make sure that the area is numb. Then we get our needle. That's the needle we're gonna use to kind of like guide our guide wire. We puncture the skin. Make sure that we don't move. While we puncturing the skin, we can move our ultrasound machine away from the needle, so we can make sure that we can see the tip of the needle in the vessel. Once the needle in the vessel, and then we can see blood return into the syringe. We put down our ultrasound machine, making sure that we stay steady on that needle so it doesn't get dislodged. We put the ultrasound machine down, we secure the needle, and then we remove the syringe, and then we make sure that we have continuous blood return. We put the syringe down, we take our guide wire, and then we can kind of like tilt down that needle at a 15-degree angle. We insert our guide wire while making sure that we're still securing the vessel. Once the guide wire is a little bit advanced, we secure it still with that non-dominant hand, and then we remove the needle. Then we use our scalpel to kind of like puncture, nick the skin. So when we advance our dilator, we don't get resistance. But when we are puncturing the skin, the sharp part of the scalpel is away from the guide wire. I puncture the skin, and then I put the scalpel down. Now I take my dilator, and I insert my dilator over the guide wire through the skin into the vessel in a twisted way. Once that's in, I can now remove my dilator again, and I take my catheter. It's a 3-lumen catheter. Before I started the procedure, I flush all 3 lumens in the catheter to make sure that there's the lumens are patent, the catheter is patent, and then also there's no air remaining in those lumens. And I clamp the other two lumens, and then I leave the brown one unclamped. So I slide it over my guide wire. Once it's in the skin, I insert it a little bit more until I see the tip of the guide wire out of the brown catheter. So now, while I'm advancing my catheter, I can remove my guide wire. Once it's in place, I insert it like about 12 to 15 centimeters into the skin, and that catheter is kind of marked. It's gonna show on the catheter. So once it's in, I take my syringe, my saline syringe. Before I flush through the brown one, the brown lumen, I make sure I aspirate to make sure I have good blood return, and then I can flush in, and then I secure my line to the skin with the clear tegaderm, and then now I unclamp each of my lumens. I flush them, aspirate for blood return, and then flush, and then now I can suture my line to the patient's skin to prevent it from dislodging. After the procedure, I educate the patient what to look for to make sure the patient watch for a sign of infections, to report any increased bleeding, and warmth and like increased pain to the area. And then I educate the patient when to go back and see his or her primary care doctor. That's pretty much it. Thank you so much.